because this is going to be a lot of listening to my boring voice. But let's get started. Components of normal movement. Our bodies, when we're born, we have patterns of development, and this is an ordered sequence of events, and everybody's different. Within these patterns are, there's milestones, but what you need to know is that there's not a strict cutoff for these milestones. They're going to overlap some, and you're not going to say at 4 months this should end, this should begin. There's a little bit of leeway as far as time goes in the patterns. So you all should know these patterns happen cephalo to caudal, proximal to distal. That's how they develop. So these babies are going to have a lot of mass movements in the beginning, nothing really organized, and as they develop, these should move into more isolated, controlled, intentional movements. And again, there's going to be an overlapping. Reciprocal interweaving, you guys just know kind of what that means, and that during development, neural pathways are being formed, and that's between the antagonistic pairs of muscles, and this has to happen. This is very, very important. Neonate. Neonates, they are dominated by physiological flexion in both supine and prone. That's very important. You guys need to know what they're doing, with what they look like when they're on their tummy and what they look like when they're on their back. They are going to have complete head lag when you pull them to sit. So if you have this baby on their back and you grab a hold of their arms and their shoulders, supporting them, and you pull them to try to pull them up to sit, their neck is going to completely fall back. It's not really, they're not going to pull their neck up. They have very limited head control. The only head control that they should have as a newborn is if you lay them on their tummy, they should be able to move their head side to side. So if you lay a baby on its tummy, day one, it should not keep its face into the surface. These babies, if you do see a baby that does this, it's it's pretty serious. You don't want to put them in that position because there's some sort of delay, or there's something that needs to be looked at further if the baby does not move their head off of the bed surface or whatever surface they're on. So they can lift their head momentarily to kind of move right and left, and their hands will stay clenched. They will follow objects. It's going to be kind of intermittent, so it won't be every time. They have a complete C curve. If you were to pull them to sit and try to have them sit up, obviously they're not going to be able to. Their back is going to be completely curved, and there are some videos later where you can look this up and see what this looks like. They're also going to stand. If you try to stand them up, and their feet are going to go kind of like they're trying to walk, and this is just a reflex. This is not a newborn trying to walk. So let's look at newborn reflexes. So reflexes, these are reflexes that they're either that appear at birth, or some reflexes are while they're in utero. And these reflexes, the majority of them that we're going to talk about are going to integrate by 4 to 6 months. So it's important to know these reflexes so that you know when something is wrong. So for example, if you have a kiddo that is still displaying a reflex that should have integrated by 6 months, and this kiddo is 24 months and they're still showing this reflex, then you could have the possibility of having some problems. So that is why this is important to see. You need to know what normal is in order to see what's abnormal. And so that's what we look at when the PT is evaluating a baby. Is they're going to test a lot of these reflexes to see, which ones are supposed to be integrated or which ones are supposed to be evident too. It's also a red flag if you test a kiddo for a certain reflex and that reflex is not showing. That would also be a red flag. So just know these reflexes and notice that there is a range that these reflexes are integrated by. So that's pretty important. So these are pretty self-explanatory. Let's move on. The ATNR is one of those reflexes that tends to still be evident in a lot of kiddos that we see in the pediatric setting, even as school-aged kids. So we still test for this because this could affect their ability to sit in a chair, their ability to step up, to step over things, because that ATNR, if you turn your head and your upper body and lower body want to do something different, it should be integrated. So that could be an issue. I think that's all on this one. Just know these reflexes. And here's videos. Be sure you look those up. So at 1 month, the physiological flexion that they're born with should start to reduce. It's going to diminish. Their head, as a newborn, when you lay a baby on its tummy or on its back, its head is going to bear most of the weight. So starting at around 1 month, you should see that weight start to shift away from the face and the head, kind of more towards the trunk. That's it on that. At 3 months, we have the beginning of symmetry and midline orientation, and just more intentional movements. Midline orientation is the ability to bring both hands to the center of your body. They're not born with that, so that starts to develop around this time. Know what these babies look like in prone and supine. This is something that is tested as well when we're doing evaluations on babies. Is by 3 months, if you put something in their hand, can they hold on to it? Are they kicking reciprocally? So, right, left, is the right and left side moving independent of each other? And are they tracking? Okay, moving on. Know what they look like in sitting and standing, and know what their limbs look like at this age. The Landau is a little different than the other reflexes that we've already talked about. It does not have an onset until around 3 to 4 months. So it comes on later, and then it integrates. It says 12 to 24 months, but usually around a year it should integrate, and that's really helps with trunk stabilization, and it breaks up that flexor dominance that these babies are born with. and it facilitates prone extension. So that looks like the parachute. Somebody is skydiving. It looks like the skydiver, not a parachute. Around 4 months, know what they're doing. They should be able to lift their head and chest up at 90 degrees when they're on their tummy. They're holding their hands at midline, so they're bringing their hands to the middle. They might be playing with their feet, or they should be. This is also something that we test as well. Can they play with their feet? Are they bringing their hands and objects to their mouth? Know what they're doing and standing. This is kind of early, but it can still happen. They start to roll, supine to prone, prone to supine. Typically it starts as an accident when they're prone to supine, as their head turns, if they're watching something or watching a mom or dad or whoever walk through the room, and their head turns, then their body will turn as well. And sometimes it can actually startle them when they turn from their tummy to their back. And then it usually goes from prone to supine. Supine to prone is a little more difficult, and that usually happens later. And to get them to start to work on supine to prone, you can typically move their leg or some limb, you cross it over to the other side of their body, then that should elicit that reflex, the body on body or the neck on body reflex that is a few slides earlier. Alright, and the STNR is starting to come into play around this time, and it should integrate at around 8 months. And this is a pretty important one because it divides the body into the upper and lower body. It helps to distinguish the relationship between the upper and lower body, and they're different. It also inhibits the TLR, so it allows creeping and crawling, and for your upper body, you need to be able, for your upper body to do something different than your lower body. So if that TLR is not integrated by 6 months, then there's a problem with baby being able to get up prone on elbows, to get into quadruped, to do reciprocal crawling, creeping. And then at 5 months, they should start to bridge. If they're on their back, they'll perform bridging. They think that every time you pass by them that you're going to pick them up, and you can tell they get really excited and they'll hold their arms up, and they should have some initiation when you're pulling them to sit. Let's see. They should be able to prop sit, and their back should become straighter when they're in this position. So prop sit is you have them sitting on the floor, and they should be able to use their arms on the surface to help them stay upright. That neck on body and body on body should be diminishing. The Landau is strong right now. They should start to have some protective extension forward. So if they're, for instance, if they're in the sitting position, they should be able to show that protective extension forward. If they lose their balance, they should be able to put their hands down to catch themselves. And so these are some, you can read some ways that we elicit this and also work on it. Because a lot of babies that do receive PT, this might be absent. So we definitely want to work on this. Alright, so by 6 months, we should be able to pull to sit with no head lag. They should be able to roll pretty consistently sit unsupported for a short amount of time. And this is the beginning of segmental rolling as opposed to a log roll. So a log roll is when they're more stiff in their rolling, and now they should be able to bring one leg over and roll if they're rolling from supine to prone. It should be less rigid now. That video will explain a lot of that too, for you to be able to see that. Alright, so reflexes and reactions. Alright, at 7 months, they will start to creep backwards. Usually that's kind of how it begins when they're starting to creep or learn how to crawl, is they push themselves backwards instead of forward. So it's not just a perfect, oh, I'm going to crawl, and then they're going. They'll start to rock in quadruped, so they'll get up on their hands and knees and just kind of rock back and forth. And this is all very important to prepare to start crawling. They should be able to sit for around 1 minute. Know that. That's pretty, all of these are, it's pretty important. Pull to sit. Okay, so when they're sitting, they should be able to kind of look right and left and rotate with trunk control, and not lose their balance. Or, in other words, they should have those protective responses to stay sitting and not fall over. These are the reflexes and reactions. So now we're going into the protective extension. It started forward and now it's going to go sideways. So they should start to exhibit those either putting their hands down or doing that lateral trunk flexion and extension to stay balanced when they're sitting. So around 8 months, they should be crawling on their hands and knees, and this is different than commando crawling. Commando crawling is, there could be intermittent lifting of the tummy off of the surface, but it's usually their tummy is on the surface and they're still performing that commando crawl, and it should start to look like a hands and knees quadruped crawl. Should be able to go in and out of sitting. Pull to stand can start at around 8 months. At furniture, alright, so 9 to 10 months, these guys are crawling around everywhere. They're into everything. They're cruising, holding onto furniture, or if you hold their hands. Now they should have that protective extension backward. So they should have it in all directions now. That SDNR should be integrated. The landau is starting to integrate. The plantar grasp is starting to integrate. 11 to 12 months, these guys are cruising a lot. And by cruising, it's cruising along furniture. That is what they prefer to do as their form of mobility. They're able to lower themselves to the floor by half kneeling. So that's lowering one knee first onto the floor and then the other. They may be able to even stand alone briefly, with maybe 1 or 2 steps. So this is important. This is an average age for independent walking, is around 11 and a half months. And you're going to have babies that start earlier. Some of you who have kids, your babies started walking earlier than that, and some walked later. What we want to emphasize is there's a range, and if you have a 16-month-old that is not walking, then that might be something that could be a red flag and needs, looked into further. So that's why we're going over these age ranges and this development, just so you kind of know when we might need to be worried. Alright, so these are some extrinsic factors that affect motor behavior. And what that means is we might have kiddos that come in for an eval and say Timmy has difficulty walking up the stairs when we're testing him. It could possibly be because Timmy doesn't have stairs at home and hasn't been given that opportunity. So, that we try to look at that, but in those instances, usually if Timmy qualifies for physical therapy, then Timmy should show quick progress if it's something to do with he just hasn't had the opportunity. Once given the opportunity, he should be able to catch on pretty quickly. So that's a good scenario. Environmental. Cigarette smoking is it could delay development. It could stunt their growth. What is it like? What is that family dynamic like? Cultural child rearing practices, how those are different among the different cultures. This is actually from the optional book, Children Placed in Supine to Sleep may be slower to develop head control in prone and upright. Really prone on elbows when they're starting to push up on those elbows. Just the importance of these babies being put on their tummies as much as possible to gain that strength, and those neural pathways are being formed while they're doing all of these movements, learning. So tummy time is very important. Alright, so some potential problem signs. So if they're just not moving, we call it a poverty of movement. If you have your baby there and they just lay there, that could be a potential issue. Babies should be, from day one, they should be moving constantly when they're awake. Poor head control. An increase in stiffness or tone, or floppiness if they're too floppy, or have a lack of tone. That is an issue as well. If they use their head and neck in hyperextension during movement, so that's usually means that there's some tone, and that's actually something that it's a pattern that you don't want them to develop, to use hyperextension to get into a position. Any type of feeding problems, choking, respiratory problems, if they're always crying. I mean, this isn't the be-all end-all, but these are definitely some some problem signs that could mean that they need to be tested or evaluated. Around 4 to 8 months, that hypotonia that we were talking about. If they're still exhibiting mass patterns of movement, because these mass patterns are very, they're very important at birth, but they should be diminishing, and they should be more reciprocal patterns of movement. or a lack of variety. If there's any asymmetry, if they're just moving one side more than the other, or maybe if they're moving their upper body more than their lower body, or vice versa, moving lower body more than their upper body, if they're staying faced to one side, if they have limited reach, or they still maintain that fisted hand, that's also something that you want to look for. And then at 9 to 12 months, you want to look to see if they have, how is their trunk control? Do they have those protective responses that we talked about in sitting? What is it? Are they grasping onto things? Are they chewing on their hands? Are they bringing their hands to midline? Are they bringing their feet up to their mouth whenever they're on their back? Any type of hypotonicity or hypertonicity? And that is all we have. Sorry about